A 54-year-old man has had colicky abdominal pain and protracted vomiting for several days. He has developed progressive moderate abdominal distension and has not had a bowel movement or passed any gas for 5 days. He has high-pitched, loud bowel sounds that coincide with the colicky pain, and x-rays that show distended loops of small bowel and air fluid levels. 5 years ago, he had an exploratory laparotomy for a gunshot wound of the abdomen. Now, before we continue, I want to emphasize the symptomatology. Crampy abdominal pain, vomiting, abdominal distension, and no gas or bowel movement. Let's say that again. Crampy abdominal pain, vomiting, abdominal distension, and no gas or bowel movement. Remember this. We're going to talk about this very importantly in a few seconds. Mechanical intestinal bowel obstruction. Let's first of all recognize something. When we deal with intestinal or bowel obstruction in general, this is a subject that sometimes causes great confusion. And so what I'd like to do is simplify things for you. First of all, the presentation, generally speaking, of all bowel obstructions is the same. Crampy abdominal pain, vomiting, abdominal distension, no gas or bowel movement. Let me say those things again. Crampy abdominal pain, vomiting, abdominal distension, and no gas or bowel movement. Whenever you hear this, the first thing that should come into your brain is obstruction. After you're thinking about obstruction, which is very easy because the symptomatology is almost identical case to case, you, not the patient, you have to answer one question. Is this obstruction complete or incomplete? Meaning, is it completely blocked or is it incompletely blocked? Because if it is completely blocked, you're not going home that night. Meaning there's an expression that says that the sun never sets on a complete obstruction. Why? Because if you have a complete obstruction, you will end up with ischemic, dead, perforated bowel if you do nothing. So, the question, before we proceed any further, is how do you determine, let's say clinically, that a patient has a complete or incomplete obstruction? Well, one of the issues is that if a patient truly tells you that they have passed nothing from their anus, nothing at all, you better worry about a complete obstruction. Meaning, we all pass gas and we all have bowel movements. Many times, if you ask a patient, well, have you had a bowel movement? They'll say, nope. But then if I ask them, has anything come from your anus at all? And they say, oh yeah, I've had some stool come out, but it's not a bowel movement. You must recognize that patients interpret the term bowel movement differently than from what you do. So your level of suspicion on a patient that says that they have passed nothing, that makes you worry about a complete obstruction. How else can you tell? Well, what about a plain film of the abdomen? What you do is, yes, you could see air fluid levels, but air fluid levels and abdominal distension can occur with a high-grade partial as well as a complete obstruction. But what you look for on a plain film is air in the rectum. Air in the rectum. If you have air in the rectum, you have an incomplete bowel obstruction. If you have no air in the rectum, you have a complete bowel obstruction. Because where's the air come from? You swallow it. And if you have a complete obstruction, your peristalsis will get rid of that air in the rectum, and it won't be refilled, so to speak. If you have an incomplete bowel obstruction, gas is continuing to go into your rectum. That's why before we used CAT scans all the time, the radiologist would call you and say there's no gas in the rectum. So that gives you a clue. Now nowadays we get a CAT scan, and the CAT scan will absolutely help you out in determining whether it's complete or incomplete. But that question is a very important question for you to answer. Because if you don't operate on a complete obstruction, that patient will end up perforating or get gangrene of their bowel, and they will die. So that question is a must for you to answer. And then very quickly, when we talk about the 3 most common causes of small bowel obstruction, the first most common cause is adhesions. The second is hernias. And the third are tumors. Those are the 3 most common causes of small bowel obstruction. The most common causes of large bowel obstruction are number 1, cancer, and number 2, volvulus. So now let's get back to this patient. Remember, this patient had a prior laparotomy. So what do you think would be the most common reason that this patient has a mechanical obstruction? Adhesions. And that would be small bowel. So you see that by just looking at the history, you kind of have an idea where you're going. Presentation, again, the presentation is exactly the same for all obstruction. Crampy abdominal pain, vomiting, abdominal distension, no gas or bowel movements. They will have high-pitched bowel sounds, which is trying to get rid of that obstruction and colicky pain. When they have no bowel sounds, that's what we call a tired bowel. That's kind of a dangerous thing, meaning that bowel is getting ready to cause a problem. Now the diagnosis, clinically, you can think about it and probably make it clinically. Not that you're going to rely on it, but clinically you're thinking already this is small bowel obstruction secondary to adhesions. If you did a plain film, which by the way is being supplanted nowadays by doing a CAT scan, but if you did a plain film, you'd see distended loops of small bowel with air fluid levels. You got an obstruction. Again, understand that nowadays they'll usually go straight to CAT scan. And remember, if you go and get a CAT scan, do you still need a plain film of the abdomen? No, because before they do the CAT scan, they do what they call a scout film, which is a plain film. Indeed, if you have a patient who has a bowel obstruction and you've already determined that it is incomplete, you can treat non-surgically by NPO, NG suction, intravenous fluids. So, hopefully that obstruction will open up. Now, when do you intervene? Now, you already know that if you have a complete obstruction, you're not going home. You're intervening straight away. But if someone doesn't get better with conservative management with an incomplete or partial obstruction, how long do you wait? Well, there's no specific answer here. You certainly do not operate after a couple days because you want the swelling to go down and give the patient a chance. You don't wait 2 weeks either. What you do is you give the patient a fair trial of conservative management. Now, obviously, if you see signs of strangulation, what does that mean? Fever, redness in the abdominal wall, leukocytosis, peritoneal signs, acute abdomen, you're operating because that patient obviously has a complete obstruction. So let's talk about another situation. A 54-year-old guy has colicky abdominal pain, protracted vomiting, abdominal distension, and no bowel movement or gas for 5 days. Again, I stress those 4 symptoms: crampy abdominal pain, vomiting, abdominal distension, and no bowel movement or gas. What word are you thinking about? Obstruction. He has high-pitched, loud bowel sounds, and x-rays show distended loops of small bowel. 5 years ago, he had exploratory laparotomy, so immediately you're already thinking that this is small bowel obstruction secondary to adhesions. Correct? Yes. 6 hours after being hospitalized and placed on NG suction and intravenous fluid, the patient develops fever, leukocytosis, and clearly an acute abdomen. This patient does not have an incomplete obstruction. This patient has a complete obstruction, which is causing a strangulation, and you can call a strangulation ischemic bowel or gangrene or perforation. The bottom line is that it's strangulated. The blood supply is cut off. Why? Because it is a complete obstruction. And yeah, the presentation, it started as a mechanical obstruction, but then you got fever and leukocytosis, and you got an acute abdomen. An incomplete bowel obstruction will not present as an acute abdomen. This patient is developing peritonitis and sepsis, and this patient needs emergency surgery. A 54-year-old guy has colicky abdominal pain, vomiting, abdominal distension, and no bowel movement or gas. Again, I stress to you the same 4 symptoms: crampy abdominal pain, vomiting, abdominal distension, no bowel movement or gas. So what are you thinking about? Obstruction. All right, he has high-pitched, loud bowel sounds. X-rays show distended loops of small bowel and air fluid levels. And on physical exam, there's a groin mass, and he used to be able to push it back, but now he can't push this groin mass back. As we talked about, this sounds like a hernia, doesn't it? In other words, it is a bowel obstruction. The lump is a hernia, and as we know, hernia is the second most common cause of small bowel obstruction. Now, clearly, in this situation, this patient has a potential for developing a strangulation due to his incarcerated hernia. And on physical examination, you could easily feel the hernia, and you can't push it back. That means incarcerated or irreducible. Now, indeed, if you were able to reduce the hernia, you would then do elective surgery and fix this hernia so this wouldn't happen again. If it was unable to be reduced, and indeed if it became strangulated and you saw evidence of infection and ischemia, that patient would require emergency surgery. A 55-year-old woman is being evaluated for protracted diarrhea. On further questioning, she gives a bizarre history of episodes of flushing of the face with expiratory wheezing, and a prominent jugular venous pulse is noted on her neck. Now, I want you to know that this is carcinoid syndrome, and if I just gave you that presentation that I just did, not many people, including myself, would necessarily come up with the diagnosis. Most of the time in this situation, you would have gotten some sort of study, meaning like a CAT scan, and you would see a tumor in the appendix or small bowel, which would then lead you with this history to make the diagnosis of a carcinoid. So most of the time in clinical practice, that's what you would see. The presentation of a carcinoid syndrome is, as they describe, flushing of the face, diarrhea, wheezing, right-sided heart valvular damage. And if you're thinking about carcinoid, you would get 24-hour urinary HIAA. And of course, we already talked about the CAT scan. But the most important thing about a carcinoid in the abdomen is, in order to get the carcinoid syndrome in the abdomen, you must have liver metastases. That's so important. You must remember that. Because in the abdomen, if you had a carcinoid in the appendix or small bowel and did not have liver metastasis, the liver would metabolize and you would not have carcinoid syndrome. Classic test question. A 22-year-old man develops anorexia followed by vague periumbilical pain that several hours later becomes right lower quadrant, sharp, severe, and constant. He's got abdominal tenderness, guarding and rebound to the right below the umbilicus, low-grade fever, low-grade white count with a left shift. This is a classic presentation of acute appendicitis. Now, in acute appendicitis, very commonly, they'll start with anorexia. Now, what does anorexia mean? Anorexia does not mean I'm full. Anorexia means that you have no desire to eat at all. And it'll start with some unusual little periumbilical discomfort. And then the pain moves to the right lower quadrant. And in that situation, then you get an acute abdomen in the right lower quadrant. Do you get a real high-grade fever like 105? No. Low-grade fever. Do you have a real big leukocytosis like 20,000? No. You have a low-grade leukocytosis. Absolutely, you can make the diagnosis clinically. If someone comes with this history and has an acute abdomen in the right lower quadrant, there is no reason you have to do any imaging studies. However, if someone has abdominal pain that has some of these characteristics but doesn't have an acute abdomen, the best test would be a CAT scan. We used to get ultrasounds. Now we get CAT scans. Recognize that many emergency room doctors will get a CAT scan straight away, irrespective of the patient's acute abdomen or not. But if they would ask you on the test or in life, if a patient had an acute abdomen in the right lower quadrant and looked like a clinical diagnosis of appendicitis, do you need a CAT scan? No. But obviously if you get a CAT scan for any reason and you show acute appendicitis, that then answers that. And the treatment of the acute appendicitis is appendectomy.